Good afternoon, everyone. Welcome to Yashoda Hospital nursing webinar session. Today's topic is pain management, anesthesia techniques, blocks, and epidural management. I'm Rajni, GM Nursing, Somajura, Yashoda Hospital. Today, we are going to discuss about the pain, types of pain, how to assess and re-assess the pain, the tools which is used to assess the pain, and the factors which are helping us to choose the pain scale. Also, we are going to discuss in detail about the management techniques, advanced management techniques, about the pain management. Today in this webinar, let us welcome our expert panelist, Dr. DSB Srinivas, DNB Fellowship in Transplant Anesthesia, Consultant Liver Transplant Anesthesia, and Intensive Care. Sir, we would like to have your valued inputs and comments post the presentation of Ms. Jeevita, AGM from Nursing Education and Training.
Okay, sure. Hi, everyone. Good afternoon. Welcome to the warm session. Yeah, I'm glad to participate in this webinar. Thank you very much for inviting me.
So now I would like to request Ms. Jeevita to take us into the detailed presentation about pain management. Over to you, Jeevita.
Thank you, ma'am. Hi, everyone. As a nurse, we all know the vital signs are very important. So as we all know, vital signs includes temperature, pulse, respiration, blood pressure, and pain. These are the vital signs. So pain is the most important vital sign where the nurse plays a major role. So let us discuss today the pain management and what is the pain, what are the types of pain, and what techniques you have to use to assess the pain, what are the different scales we have to see pain assessment. Let us discuss one by one. So as I mentioned, first we'll see what is pain and what are the different types. We have different tools that also we'll discuss in detail, and also few factors to be considered to assessing the pain. And apart from that, after assessing, as a nurse, we should be more careful and more means you have to focus more on management of the pain. Either it could be pharmacological or non-pharmacological management. And at last, we'll discuss about the nursing responsibilities of a pain management. So a pain, usually pain is an unpleasant feeling. And most of the time, what happens in pain, the patient feels discomfort and he has emotional experiences with actual or potential tissue damage. Usually what happens when the patient gets pain, especially the nerve receptors will be there, which are called nociceptors, that will give the signals to the spinal cord to the brain. For that reason, the patient may have a sensation of the pain. So the types of pain, yes, we should aware of different types of pain. Those are acute pain, chronic pain, nociceptive pain, neuropathic pain, and radicular pain. As we all know, acute is a sudden in onset and short in duration. Example, in acute pain, what happens most of the time, if they had any cuts or a bruise, because bruise also we may not, will have the pain, but the destruction of the blood vessels may not be happen. And whereas in chronic pain also, it is in a longer in duration and it is constant pain. Example, you can take like fibromyalgia and patients with cancer patients and pancreatic patients. We have different pains. So for that reason, you should aware what is the different pains and how you have to assess. Then next is nociceptive pain. In nociceptive pain, mainly there is a damage of the body tissue. So this type of pain you can see in the like sports injury. If the patient had any body tissues injuries, then the patient may feel the nociceptive pain. Neuropathic pain. This is also one type of pain where you can see the damage of the nerves, especially in the like Parkinson's disease, where there is a disruption of the nervous system, which may lead to the neuropathic pain. And radicular pain also one type of pain where the spinal nerves gets inflamed. So as a nurse, what I would like to emphasize after this seeing this slide, you should be more aware of acute pain and the chronic pain. So as I said, this is a short in duration and the chronic pain is longer in duration. Then next, yes, if the patient complains about the pain, as a nurse, what you're supposed to do? You have to assess the pain. So if the patient complains about the pain, we should not focus more on the pharmacological management. First, you have to assess the proper pain. So to assess the pain, one mnemonic you can follow, Socrates. So the Socrates stands for the site of a pain. S stands for site. Yes, you have to ask the patient where is the pain, exactly the site, whether in the region. You need to ask where exactly the pain is starting. Then you have to ask for the onset, because as I mentioned earlier, we have the pains are different types. So you have to find out what type of pain you need to ask for the onset, whether it has started early or it is a chronic pain or you are getting intermittently. Everything you need to focus on this onset. Then character. Yes, few pains are very dull, few are in very sharp, and few will be like a pricking sensation. The patient will have different pains. So you need to ask for the character of the pain. Radiates, especially if you take the MI patient. MI patient, they have like radiation pain. The pain will be radiate to the shoulder. So that will be addressed when you ask about the radiation and associated symptoms. For example, if the patient had pain, they may have other symptoms like nausea. Other factors also could be addressed. And time and duration, this also to be considered when you assess the pain. And relieving factors, how the patient, if he takes any measures, how the pain is, whether it is reducing or aggressive. And severity of the pain, because the severity is very important to take the appropriate measurements and appropriate management of the pain. Is it clear, right? Socrates, the site, everything you have to ask. Then next is the pain assessment tools. So can anyone write what are the different types of tools we have? Later we will discuss. Okay, so the main we have the scales are numerical rating scale, visual analog scale, behavioral pain scale, and flag scale. Numerical rating scale, mainly the numerical, see, whenever you address the scales, you mainly you have to see for the age of the patient, because as I mentioned the earlier scales, first you have to consider what is age, because sometimes what happens, same scales we can't use for all adults. So the pediatric patients we have to use for the flag scale, and what is the physical condition of the patient and level of consciousness. Because if you take like numerical or Wong-Baker scale, the patient can't you have to see for the patient response as well. If the patient is unconscious, we can't use the different scale, like Wong-Baker scale. So for that reason, you need to check the conscious level of the patient, mental status of the patient, and as I mentioned, ability to communicate. Because few scales are very helpful to see how the patient is explaining, whether he could able to respond as per the scales, as per the severity of the pain. So these factors also to be considered in assessment of pain scales. So the numerical rating scale, the name itself you can tell, numerics are the numbers. So in numerical rating scale, what happens, you have to give this one, and you need to ask the patient to rate, like from 1 to 10, how much you would score after your pain. Either 0 means it is no pain, 10 means worst pain. By seeing this scale, we can identify whether the patient is having pain or pain is there or not. We have to see. Then visual analog scale. This is also one type of pain assessment scale, and the Wong-Baker faces scale, where you will use the pictorial, like images can be given, this type of scales to be shown to a patient, and you need to ask the patient to see where he is standing. Either if the based on these images, they can express their scores. If the patient gives 2, might be he feels that little bit pain. If he gives 6, it hurts more, and if he gives 10, it hurts a lot. Means the patient could not bear it. As I said, the patient after assessing the pain, it has been classified into mild, moderate, and severe. Because 0 to 4 is a normal. When the patient tells about the score is 4 and above, the interventions can be taken. For that reason, whenever you assess the pain, you have to be very careful. So this will be used for the non-verbalized patients, those who could not, and based on the facial expression. Apart from the numerical scale, this visual analog scale also, Von Baker scale, which will be helpful to address the pain easily. In this also same, the minimum score is 0, the maximum score is 10. So in between, as I mentioned, 4 and above, the interventions can be taken to manage the patient pain. The next scale is behavioral pain scale. As I mentioned earlier, the behavioral scale is used for unconscious patients and those who are unable to, especially the ventilated patient, because they could not express their feelings. So based on these parameters, which has been categorized into 3, those are facial expressions, upper limbs, and complaints with the verification. In this maximum, each parameter is having 4 score and minimum is the 1. So same, if the patient is complaining, means 3 means he is not giving that much, and maximum score should be like a 12. So in this also, if you come, if the score is 4 and above, then the interventions can be taken. The next is FLAC scale. FLAC, which will be used for the pediatric patients, especially 0 to below 5 years of age. In the FLAC stands for F means face, L legs, A activity, C cry, and one more C stands for consolability. In this also, maximum score is 2, minimum is 0. So means each parameter maximum score is 2. Based on the expressions, you have to consider whenever we see about the pain assessment of the pediatrics, that time we'll discuss in detail about this scale. Yes, so till now we have seen the definition and what are the types and how you have to assess the pain. Now you have selected the scales and you have assessed the pain. If the patient said that the pain score is more than 4, the pain management also very important. If pain score is below 3, the interventions are different. If the pain score means more than 4, what are the interventions can be taken? Those are non-pharmacological and pharmacological. Non-pharmacological, the name itself, it is indicating without administering medication, you have to manage the pain. Yes, when the patient complains about pain, most of the time we should not go for pharmacological. Yes, of course, the severity based treatment can be addressed, but if it is relieved by the non-pharmacological, priority can be given to the non-pharmacological medications, means interventions. Those are like weight reduction, massage, relaxation therapy, hot and cold applications, TENS, and acupuncture. Can anyone write what is TENS in the chat box? Okay, we'll see. Mainly the massage. See, few pains like if they have any muscle spasm, you can do the massage, and application of hot and cold also will relieve the pain rather than taking pharmacological medications. Like mainly if you apply the hot application, there will be a vasodilation. So what happens, especially the spasm will be reduced. And cold applications, like which also known as cryotherapy. If the patient had any swelling or inflammation, those pain will be reduced by the application of this cryotherapy rather than taking the medications. And because what happened, most of the pharmacological medications, if you use, the patient will be addicted to that. So you have to be more focused on non-pharmacological than pharmacological. But one point I would like to address here, if it is very severe pain, do not go for non-pharmacological. First, pharmacological will be taken into a priority. Then we have to go for non-pharmacological. Then TENS. TENS is, this is a transcutaneous electrical nerve stimulation. This is also one of the non-pharmacological technique where they will reduce the pain by giving less electrical voltage, and acupuncture, which they will address the trigger points of the pain. And pharmacological management are divided into analgesics, adjuvants, and others. The analgesics, we all know, because as a nurse, most of the time we see the analgesics which will be prescribed for the patient to manage the pain. Those are again classified into opioids and non-opioids. Adjuvants, rather than analgesics, it's like a supportive treatment for the pharmacological, and others we do like regional anesthesia, that we'll discuss in further slides. The non-pharmacological methods, as I mentioned, the weight reduction, these are the techniques will be used to reduce the pain rather than using the pharmacological medications. Then pharmacological medications, whenever you use, This is the pain ladder technique as per the WHO, which it is suggesting that the pain, as I mentioned, the pain score is 10. In that, mild, moderate, and severe. In like that way only, we have to maintain the treatment as well. If the patient is in mild pain, so first you have to go for the NSAIDs. The NSAIDs are non-steroidal anti-inflammatory drugs. For example, you think if the patient is complaining about head, first we have to see for the any application, and if it is not subsided, then we may go for like simple like paracetamol. Then weak opioids, either it could be like diclofenacs we can give, and strong opiates. Fentanyl we can use, these two types, but whereas in fentanyls can be used in case of severe pain. And fourth stage, this is the last stage where you have to use like regional anesthesias, epidural. So these are the stepwise. As the patient complains about the pain, then you need to take the interventions as a ladder. For that reason, the WHO is recommending whenever you advise for the pharmacological management, this ladder will be helpful to assess the pain and to manage the pain. Then pharmacological management, as I said, analgesics, which are divided into opiates and non-opiates. Mainly the opiates are efficacy. See, opiates are the narcotics where the strong, you can see this picture. Yeah, same whatever I mentioned the before slide, which will be the weak opiates. And for example, see, tramadol is a weak opioid. Why? Because previously some few days they considered tramadol also is a opioid. But why? Because now also it is considering, but comparatively, if you compare with the fentanyl, tramadol is having less respiratory depression. For that reason can be used, and the protocol also we have to follow as a like opioids. And prototype, mainly why we will avoid for the opioids means they may get the dependence of the opioids. For that reason, we have high risk medications and the narcotic medication. We have different policies, because to maintain the policy means to prevent the addiction of the medication, these policies have been developed. And anti-inflammatory, we have like non-opiates and antipyretic. So apart from that, even we use like topical applications like a fentanyl patch and diclofenac patch. So one thing I would like to address here, whenever you apply the fentanyl patch, make sure that the patch could be applied over where the less area of the air growth, because of the means efficacy. If you want to see, mainly the application should also to be addressed. And diclofenac, and if you apply for any children or any mental means the mentally retarded patients, try to apply backside, because to prevent means further complications. And diclofenac patch, yes, the diclofenac patch also will be used as a topical rather than administering a medication. You have to apply wherever the patient complains. Most of the time, which will be used for the orthopedic patients, like if they have any low backache or any like leg pain, for those conditions, you can use for this patches. As I mentioned, see, fentanyl patch, it should be applied. These are the regions, because as a nurse, you should be very careful where medication means, yes, we may give through IV or IM. At the same time, topical application, how you have to give also should be aware of it. Wherever you want to place, you can't place the patches. So we have specific location. Based on that, try to apply the patch and try to see that effectiveness will be seen. Like we use the diclofenac patch, lidocaine patch, fentanyl patch. So based on the doctor's advice, the patch can be applied to a patient to control the pain. Then adjuvants. As I said, the pharmacological has been divided into 3. Already we have seen the analgesics, which has been classified into opiates and the non-opiates. And adjuvants, yes, these are the adjuvants are the supportive treatment where you can use with the analgesics like antidepressants and sedatives. Sometimes we may use muscle relaxants also to relieve the pain. Then last is the regional anesthesia. Yes, this is also one type of anesthesia where specific part of the body can be make the numbness and to perform for the surgeries. So regional anesthesias again has been divided into spinal blocks and the epidurals. The spinal, the name itself we can see. See, you can look at this picture. Mainly the spinal anesthesias will be given into the spinal cord. See, this is where they are giving this injection. most probably could be like L3, L4 we have to give, because it starts from the L1, L2. So what happens if you, to prevent injury to the spinal cord, you have to inject in this area. Epidurals also same, whereas epidurals are given into the epidural space. Spinal blocks especially we give for the any abdominal surgeries, and epidural injection nowadays we are giving for the mother, and for LSCS most preferred we are using for the epidurals. And in these both anesthesias we use the bupivacaine or ropivacaine or levobupivacaine. These are the medications where we are using frequently to make the part like numbness. So whereas in epidural anesthesia they may not use injections which can be given through a catheter. So as a nurse, when the patient is on epidural, you have to check for the patient's any back pain is complaining, and what is the level of the consciousness level of the patient, proper positioning. These are the things also to be addressed when the patient is on epidural anesthesia. And spinal anesthesia also same, when they are giving the spinal blocks. So comfortable position also very important to prevent further complications to your patients. The next is nerve block. This is also one type of management of the pain by giving the blocks. Here what they do, the specific nerves will be they will make the impulses to stop to the brain. For that reason the patient may not have the pain sensation. This is also one type of pharmacological management where they are using to control the pain. Then patient control analgesics. Yes, this is also recent technology, means we are using most of the time. This is also same, patient control analgesics pumps will be there, and we set certain ml of the medications, and we ask the patient whenever the patient feels pain. This we'll ask the patient, instructions will be given to a patient to control the pain. So yes, this is our responsibility. Mainly whenever you do the pain assessment, first and foremost, you all know you have to assess every 4th hourly, and whenever required. For example, if the patient complains about any pain, or if the patient is coming from any invasive procedures, you have to assess the pain. And initial treatments, whenever you start take the pain assessment, if the score is 4 and above, please try to take the interventions. And once you have taken the interventions, especially the oral medication, try to see for the reassessment after 1 hour. If you administer any parenteral medications, make sure that the reassessment to be done after 15 minutes immediately administration of the medication. So now this is a time to ask questions. Like a nurse is providing non-pharmacological interventions for a patient having pain score 3. So as a nurse, what will you do? Like additional comfort using extra pillows, hot and cold applications, reassurance you will give, or all of the above? Yes, the option is all of the above. Most of them are answering yes. As I mentioned, the non-pharmacological techniques, you have to see for the hot and cold application based on the patient pain, and reassurance to be given to decrease the patient pain. And as I mentioned, doctor advised to administer, you all know the pharmacological interventions to be taken if the patient pain score is 4 and above. So when pain assessment should be performed? Only during admission, or every 4th hourly, after every invasive procedure, or whenever patient complains of pain, or all of the above? Yes, the correct answer is all of the above. Good. So last take home message, what I would like to tell means reduce the pain and reclaim life. And apart from these, if the patient complains or if anyone is having pain, try to address as early as possible. Never neglect any pain. So based on the pain symptoms, you have to take the interventions and reduce the pain of the patient, reclaim the life. Last quotation, pain is like inevitable, but the suffering is optional. So think and try to reduce the patient pain and make patient more comfortable. Thank you all.
Good presentation, Pratusha. Hope our audience is following you very well, and you made it very easy to understandable. Today, we are very happy to inform you that our expert panelist, our Dr. B. Srinivas Garu, he is our consultant liver transplant anesthesia and chief intensive care area. He is one of the renowned pain management consultant with us, working since long time. Sir, I would like to just address an overview on the pain management, keeping in mind about how important for nurses to knowing the techniques, how to assess the pain, and how to make the patient satisfied, because most of the time patient get dissatisfied if we don't manage the pain properly. So just overview on this topic, sir.
Okay, thank you, Amar Garu.
Yes, sir.
Congratulations, you did a very well presentation. You elaborated all the aspects of the pain very well. I will give my inputs. Actually, most of our nurses deal with post-operative pain. After the surgery, most of our patients complain pain and they are in the wards and they will complain repeatedly. Sir, pain, sister, pain, like that. So the first thing is, the concept of pain, it is a noxious stimulus. Yeah, that's all of you knows that.
Okay.
And pain pathways always has a connection with the limbic system, that is emotional attachment. That's why the pain and emotions are the integral part of the, emotions are the integral part of the pain. Most of the patients cry on pain sensation, right? So assurance, psychological support from the nurses is very well required to get to give the pain relief. This is better than medicines also sometimes in cases of mild pain. Now, I'm not talking about all the pains. So second thing is preemptive analgesia. This is a concept where we work inside the theater. We will block the signals, actually, the preemptive, before the onset of the symptoms, pain threshold or pain symptoms. So before the onset of pain, as we are giving analgesics, the pain pathways are not transmitting the signals to the brain centers, cortex, sensory cortex. So we are obstructing the pain pathway. In that way, we are giving pain relief. This concept is the preemptive analgesia, which usually we follow inside the theaters. In cases of, the anxiety and chronic pain, patients who are having chronic pain, suppose the patient is not having, is recently underwent surgery for the limb amputation, those patients will have chronic pain. So these patients, anxiety and chronic pain, again, the reassurance, psychological support, mild anxiolytics will help. So in this way, the pain management differs from the normal patients. Yeah, coming to the epidural anesthesia and epidural analgesia and blocks. Yeah, they are playing a very crucial role nowadays. So before going to epidural analgesia, I will tell you one concept: differential blockade. The drugs are same: levobupivacaine, bupivacaine, and ropivacaine. We usually use these three common drugs. But the thing is, the strength varies. For anesthesia, that means for muscle relaxation also, for undergoing surgery, the dosage and strength is more. Take for example, for you to understand, take for example, for bupivacaine, to give anesthesia, or for if the patient is undergoing surgery, we will give full dose, that is 0.5% strength of bupivacaine, 10 to 15 ml as a dose, so that it will give anesthesia. In case if you want that for only analgesia, we will reduce the strength, that is 0.125% only. Why I am telling is, in labor analgesia, the motor blockade won't be there. Only the sensory pathway should be blocked. So this concept of blocking only sensory pathway is called the differential blockade. That is why epidural is becoming popular in cases of cesarean sections and painless labors. Those epidurals are called as walking epidurals. And next thing is the regional blocks. Yeah, regional blocks, they are playing very crucial role even in acute management and chronic management. Like you said, for example, if the patient is undergoing some laparotomies, instead of, if there is a contraindication for epidural, or if we are unable to get the epidural, then we can give regional tab block, that is transabdominal peritoneal block, so that we will inject 10 ml of local anesthetic on either side of the abdomen, so the patient will get good analgesia. Good analgesia. So these are the one of the type of blocks. And in case of chronic pain, we will obstruct the signal by ablating the nerve pathway either by radiofrequency ablation or by alcohol injection or phenol injection. So that is for chronic pancreatitis or some other cancer pains we will use. And for managing the complex pain and chronic pain, another way of following is this one, transdermal patches. As she told, fentanyl patches are playing a crucial role, and we can apply anywhere on the body, not exactly on the part where the patient is suffering, but on the non-hairy area, clearly on visible area, so that we can have an idea that patient is having the patch, and it prevents further complications. Like applying another patch, and suppose if it peels off, patient may tell you that I'm not having patch, I'm pain like that. Then we can this one. And she told about the adjuvants. Yeah, adjuvants are very much useful in chronic pain and complex regional pain syndromes. For us, for acute pain management and postoperative pain management, we are not using adjuvants, but certain adjuvants we are using, but okay, no problem about that. Coming to for nurses, assessment of the pain is very, very, very crucial. They have to learn the Wong-Baker scale, visual analog scale, or numerical scale. Any of the two scales should be known to them, so that the patient can, nurses by going there, they can assess the patient pain by just observing the faces of the patient. Even without asking also, most of the times you can assess the pain. And the behavioral pain pattern is very important for the patients in ICUs and on ventilators, and also for the patients who are psychologically ill. Of course, FLACS score is for pediatric patients. So anyway, intervention is only applicable to patients who are having pain score of more than 4 on any scale. Either it is Wong-Baker's or FLAC or behavioral scale. The above 4 is considered to be interventionable. Below 4, it is mild pain, no need to intervene. The thing is, the reassurance, psychological support plays a crucial role if the patient is having mild pain. Second thing I want to tell you is, one of the thing is, most of the laparotomy patients or LSCS patients or orthopedic patients or patients who underwent surgeries under spinal anesthesia, they may get, we all have that myth of backache after spinals, right? So why do this happen? Actually, the spinal cord relaxes completely after the spinal anesthesia. So that causes the stretch of the ligaments. So that may cause the disc prolapse. To prevent that, for the patients you receive in the post-op ward or in the wards, put a pillow under the thighs or legs. This simple precaution prevents the backache incidence in our patient population. This thing I want to address. And second thing is, after telling the patient, telling to the doctor, nurses should follow the instructions. Suppose diclofenac, if you have to give diclofenac, you have to give it in 100 ml dilution only. Don't give it directly IV. If you give IV directly, it will cause nerve damage to the local area. So that should be done. And the positioning of the patient is also very important. Most of the patients just flex the legs will also, suppose laparotomy in patients who are undergoing laparotomies, just flexing the legs will help the patient to get pain relief. Second thing is, and nowadays we are giving PCS, patient controlled epidural analgesia systems. She told about that missions. Actually, we are using that for epidurals. We can use it for IV analgesic infusions also. For IVs, we can use fentanyl. You may have the doubt the fentanyl is toxic, and if you give in more doses, it may be harmful. But patient-controlled epidural analgesia system is safest. Why? Because we will keep the lockout interval. What is that? What does that mean? First, before going to that, What is patient-controlled epidural analgesia? It is a mission. Patient can control his own analgesia, own drug device, that drug delivery. Suppose if you connect the patient to the mission, if the patient is having pain, he can press the remote on that mission so that additional drug or the dose is delivered so that the patient will get pain relief. If the patient is either psychologically ill or if the patient is unable to get the adequate relief, then they go on pressing that remote, which may deliver the drug in large doses, resulting in adverse effects of the drug. To prevent that, we will keep the lockout interval. That is the safety interval. We usually keep 4 hours as the safety interval for local anesthetics, 1 hour for the fentanyl. Fentanyl usually will go away from the body within 45 minutes to 1 hour. So that after the dose, if the patient waits for 1 hour, nothing will happen. So we will keep 1 hour as a lockout interval in PCS for fentanyl, 4 hours for local anesthetics. Ideally, 90 minutes is the recommended for IV for epidurals, but we are keeping as 4 hours. Next thing is for nurses, as the site of epidural catheters or any other femoral catheters, daily inspection like center lines to be done. Second thing is observe for the side effects of the medicines. If patient is on narcotics like fentanyl or opioids, other opioids, they may have some itching sensation or urinary retention, or some patients may have respiratory depression. Most of our opioids are safe. Actually, fentanyl, it won't cause that much respiratory depression. Morphine is the very potent agent that causes respiratory depression. Most of the times we are not using morphine. Nowadays, better analgesics are there: buprenorphine, nalbuphine, butarphenol, fentanyl. These are all available, more potent and less addictive. So we are using those. But anyway, from nurse's point of view, they have to observe, they have to assess the patient properly, they have to guide, because you people are the really, really good people. We are all dependent on nurses for their assessment, and their part is very essential for our success. And regarding TENS, she told about TENS. TENS is the transcutaneous electrical nerve stimulation. It is, I will tell you one example. In some movies, you can see, suppose if one scene I will try to depict here. One tiger is about to hunt one baby. Suddenly, the baby's mother or father saw that picture. So they want to save the baby. What will they do? They will divert the tiger towards them, right? Assume that the small baby is the pain conducting nerve fiber. Tiger is the pain stimulus, right? Big fiber, the father or mother is the large fiber. Just in the same way that through the TENS, we are just diverting the pain stimulus towards another nerve fiber. So A delta fiber and C fibers are the nerve fibers which carry fibers to the, pain stimulus to the central cortex. In TENS or acupuncture technique, which are commonly used for chronic pain or complex regional pain syndromes, we are stimulating the large fibers, large A beta fibers, like most of the times A beta fibers, so that the pain stimulus won't be carried to the brain. Before that, this A beta fiber, the pressure sensation or lower threshold sensation, will carry to the brain, which obscures the low intensity signal. In that way, we are obstructing the pain pathway. In that way, the pain relief you will get. So that's all about the TENS and other things. So that's all from my side. For nurses' point of view, assessment of the pain, PCS management. Sometimes you have to give reassurance and educate the patient regarding PCS also. These days we are putting PCS for every epidurals almost. So, and positioning the patient. Some precautions like pillows underneath the thighs will prevent the future back pain. These are all the steps which are crucial in the management of the pain. Thank you very much. Sir, you are not audible, sir.
You covered most of the points, sir. Acute pain management, chronic, post-operative care, and especially assessment of the nursing assessment matters a lot in pain management because they are the one who can raise the flag on that one. You can do it. So just overview on the just epidural management, sir, because most of the nurses are handling day to day. Some errors we do most of the time in epidural management. What need to look more as a nurse in care of epidural care?
Yeah, epidurals. One thing is most of the nurses will. I mean, everyone, even doctors are also afraid of hypotension and bradycardia because of epidurals. But as per me and as per the studies, the continuous infusion, whatever the strength, yeah, as I told you, differential blockade. That is,
Yes.
we are putting the strength to block the only the pain pathway. That is 0.125% or 0.2% root working.
Yes, sir.
So the continuous infusion won't cause fall in BP that much. I mean, not more than 10%. So up
Yes,
to 10%, patient will tolerate.
Right.
If there is fall in BP more than 15%, give 100 or 200 ml of fluid, but after informing the concerned anesthesiologist or concerned surgeon or some duty doctor, so that the hypotension will be addressed. Second thing is, despite the epidural, most of the patients, I mean, some patients may complain of pain. So for them, we have to supplement with either IV analgesics, I mean, some more analgesics or transdermal patches. One thing I want to tell you here, I mean, I will go to that point next time. The third thing is PC emissions and epidurals. The catheter site insertion should be watched carefully, daily dressing about the leaks or bleeding, everything. Fourth thing is neurological assessment of the patient after who are on epidurals. The neurological assessment is though we are giving the strength which is enabled to block the sensory blockade, which is unable to cause this sensory blockade, sometimes there might be some weakness in the muscles also. So that should be assessed by assessing the strength of the muscles. So these are the aspects we have to take care of this. I forgot to tell you about the multimodal management of the pain.
Okay.
Multimodal management is most of the patients, sometimes, suppose, if a sensitive patient, pain is subjective. Remember, pain is very subjective. It varies person to person. So some patients may require more analgesics or they anticipate pain score of 0. Some may anticipate, some may tolerate well. Even 6 on pain score are also well tolerated by some patients. So for patients who requires additional pain relief, we are using different modes of analgesia. That is, one is either epidural, regional, plus IV, plus or minus transdermal. These are the things. Like stepwise, step 1, step 2, step 3, step 4, we are using this multimodal, I mean, different modes of administration of analgesics to give the pain relief.
Yes.
So,
thank you, sir. You covered most of the topic, and thanks for giving your valuable time. So we'll try to have one workshop on pain management. It's a very interesting topic, so that we can discuss and that elaborate. I think half an hour time is very short.
yes.
So go into the depth. So thank you so much. Thank you, Jivita. You given an excellent presentation. Ms. Rajni, madam, thank you as a moderator. Excellent. You did. And Pratyusha, all of you. Thank you. Thank you, sir.
Thank you. Thank you very much for inviting me. Yeah.
Thank you, sir.